Hello, everyone. Welcome to the next part of Module 3, Bias in Epidemiologic Study, where we're going to talk about information bias. So far, we've talked about DUGs, how we use them in epidemiologic studies. We've talked about confounding and how we might be able to address confounding in the design stage as well as in the analysis stage. In the previous part, we've talked about selection bias. Lastly, we'll talk about information bias. So the objectives of this are going to be to first define what information bias is, to understand the difference between random and systematic measurement error, learn about some common types of information bias, and discuss on ways how we can minimize information bias, particularly in the design stage. So let's start with the definition. Information bias is one type of a systematic error that occurs in epidemiologic study. This is nothing but a systematic difference from the truths that arises, be it in the collection, in the recall, recording, or handling of information in a study. It could be bias in an estimate arising from measurement error, where we may have flaws in measuring, be it the exposure, the covariate, or an outcome variable that results in a different quality or accuracy information between our comparison groups. So sometimes it is called measurement bias because that's one of the major reasons where we could have information bias. And sometimes it is also called observation bias, because if you have an observation that is involved in your epidemiologic study, that bias in measurement could be introduced by observation. And measurement error in discrete variables is often called misclassification. So you might hear the same information, measurement bias, observation bias, misclassification, or information bias, describing the same thing depending on the study question, depending on what is involved in data collection. So let's look at this diagram to clarify what we mean by measurement error. So on the left side, we have random measurement error, where this is the truth, and you can see that there is really no pattern on how the errors are occurring. All measurements are prone to random error. So this could be a normal fluctuation or inconsistency in measurement. So factors that minimize random error include having a larger sample size or repeated measurements. For example, if you're measuring height or weight, we tend to measure 3 times. That way, having multiple measurements would provide a way of minimizing the random error. Another type of error that we have is a systematic error, where the measurement is systematically different from the truths. So we have the truths here, but the measurements are higher compared to the truths. Unlike the random error, where there is really no pattern, in the systematic error, they are systematically different. So this could be the case where you have a blood pressure measurement, for example, that measures or that always have a higher blood pressure assessment, more 10 millimeter mercury higher compared to the actual blood pressure measurement. So in that case, you might need to reconsider the instrument. It could be the case that you have a specific nurse who measures consistently higher or rounds up the numbers. Or you may have an assessment scale that tends to capture certain things that would artificially inflate the estimate that you have compared to the truth. So random error and systematic error. So we care more about the systematic error. Of course, we care about random error, but this one is easier to fix. So we may have two types of measurement errors, particularly in the systematic error. The first one is non-differential measurement error. The second one is differential measurement error. A non-differential measurement error, as the name implies, it occurs if there is an equal misclassification of the exposure between subjects that have the disease or that do not have the disease, or there is an equal misclassification of health outcome between the exposed and unexposed individuals. If the exposure or the health outcome is dichotomous, then this non-differential misclassification, oftentimes we say that it biases the estimate towards the null. So you have the truths, group 1 and group 2. So it's equally higher in both groups. A differential measurement error occurs when the misclassification of exposure or outcome is not equal between the two groups. So it's higher in this case, but it is lower in the second case. So the direction and the magnitude of measurement error might depend on the variables with measurement error. It could be the exposure, the outcome, and the covariate. And sometimes it could depend on the variable type, be it a continuous variable like height, weight, or a categorical variable. Whether the error is about the same across groups, which is non-differential or non-differential. So the direction could be different. If you have a non-differential, as I mentioned, it could be different in how the error might affect the magnitude of the association between our exposure of interest and our outcome of interest. And we have different types of selection bias. We have recall bias, observer or interviewer bias, reporting bias, performance bias, detection bias, instrument bias. Those are just simple examples, but there are other types of information bias that may be introduced in observational studies. Let's look at the classic bias, the recall bias. The recall bias, or oftentimes called as reporting bias, is a type of an information bias that occurs due to differences in the accuracy of recall between cases and controls, or a differential reporting of health outcome between exposed and unexposed individuals. So if you have a study where there is systematically a difference between the exposed and unexposed, or diseased and diseased group to recall their history of information, then this type of bias is introduced. It is common in retrospective study designs. As you know, case control study is also going back in time, so that is also another common type of bias that you see in case control studies. So let's take an example. If we ask parents of children diagnosed with cancer, they may be more likely to recall history and informations like infections earlier in the child's lifespan than parents of children without cancer, because exposed individuals are more concerned about their exposure and may over-report or may accurately report the occurrence of symptoms because they're asking questions about their history of exposure. Or we could have another example where cases with multiple episodes of depression as an adult may be more likely to recall and report history of trauma and child abuse than controls with no history of mental health problems. So this type of bias is classic in epidemiologic studies, particularly in case control study or in retrospective lead design studies. This is an example, a case control study of vigorous exercise as a risk factor for cardiac arrest that was conducted in 1984 by David Siskovic and his colleagues, where they were comparing information trying to understand the risk of cardiac arrest. The investigators in this study obtained information from the wives of men in whom a cardiac arrest has happened and compared that with those in the community. Although it would have been possible for them to interview the control men who didn't have the cardiac arrest. So you have cases with cardiac arrest and controls without the outcome. The cases were sicker and they were not able to talk. So instead of asking the kids about their history of physical activity, they decided to ask the wives of the cases. In order to have a comparable information, they decided to ask the wives of the controls, even though it was possible for them to have an interview information from the controls themselves. So having a comparable recall was an important criteria that the investigators used. So they were willing to accept the likelihood of greater exposure misclassification arising from the use of interviews with the spouses of controls as well as cases, instead of having a higher degree of case control data from both groups. So this is a classic example that we use in epidemiology to talk about recall bias. Another type of bias that we may have is interviewer bias. So this is the case where different observers may assess subjective criteria differently. For example, different nurses can have different habits of rounding blood pressure reads. And the knowledge and hypothesis under investigation or the disease status or exposure status might lead the researcher to ask questions or assess subjects differently. So oftentimes when we train interviewers or research staff, we don't tell them the specific hypothesis of the study. So because observers may have a preconceived expectation of what they should find in an examination or in a research. So for example, an investigator who believes that history of childhood sexual abuse causes depression in adulthood might put an extra effort in obtaining disclosure of abuse from subjects whom they know to be in depression case group. So blinding or not telling the specific hypothesis would be important. Or we could have infants whose mothers reported having taken a specific type of anticonvulsant for any medical indication during pregnancy are more likely to be diagnosed with midface and digit hypoplasia. So this is something that we oftentimes think about in case control study designs, trying to ensure that there is no difference between the study participants based on interviewer or observer. The other type of bias is a reporting bias. So reporting bias can collaborate with, participants might collaborate with researchers and give answers in the direction that they perceive are in the interest or the research. And they might give answers that they perceived of interest. Participants may change their information because they know or believe that what the researchers want to hear. We oftentimes call this a social desirability bias. So you may have issues where there could be underreporting of certain exposures like alcohol consumption, or there may be overreporting of physical activity. Another type of bias that we see in information bias is performance bias, where participants may modify their behavior or responses because they are aware of the group allocation. So this is when study personnel or participants modify their behavior. Oftentimes, this is seen in intervention study. For example, participants in a control arm of a weight loss trial may feel upset that they are not losing weight, and they could initiate other healthy behaviors, even if it's not part of your research protocol. There's also related to this, we have what's called Hawthorne effect. Because subjects' behavior might change, the fact that we're observing them. So a reaction changes as a result of observation. So as a result of being in a study and being observed could change a subject's behavior, which may not necessarily be related with your objective of the study. Other type of information bias, we have detection bias, which could occur where the way in which outcome information is collected differently between groups. So if you have, for example, a psychiatrist assessing cases and a research assistant assessing controls, you may have an issue of detection bias. We could have an instrument bias. This is when you have instruments that are inadequately calibrated, measuring systematically, underestimating or overestimating. So this is something that we oftentimes try to do, a reliability of instruments at the beginning of a study. Another type of, the ways that we try to minimize bias is by blinding sometimes, keeping participants and observers blind to the hypothesis under investigation makes it easier. So blinding can be encouraged by making the title of the study non-specific. So for example, we have a study that looks at the effects of maternal exposure to mood and anxiety disorders in relation to preterm births. We don't call it that. We try to provide a more generic name. We call it Healthy Moms Study. So trying to make the study non-specific by including those type of names allows to keep participants and observers to some extent blind to the main hypothesis. And sometimes blinding the investigator of subject's exposure or outcome status would be important if they are involved in collecting data. This is something that we overemphasize, which is adequate training for interviewers and retraining and making sure that there is a standard assessment is important. And having multiple observers as much as possible and trying to even randomize them could help in minimizing information bias. And using standard questionnaires is also something that we try to use. This way, the study data collectors are not introducing bias. And we try to do also validation of instruments. This is something that we'll discuss in the next module, where it is important to use instruments that have good psychometric properties to ensure that we are collecting valid information from our study participants. So this concludes our module 3. We've talked about DAGs, we've talked about confounding, we've discussed about selection bias, and also touched a little bit on information bias. In the next module, we'll talk about effect modification and interaction.